Welcome everyone to today's webinar, Augmented Reality in Academics and Training, Beyond the Status Quo. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'll walk through a few quick housekeeping notes. We'll begin today's webinar with a presentation and have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to welcome today's speaker, Dr. John Shin. Dr. Shin is an attending neurosurgeon at Massachusetts General Hospital and Associate Professor of Neurosurgery at Harvard Medical School. He's a Kingdon Saylor Endowed Chair in Spine Neurosurgery and Director of Spine Oncology and Spinal Deformity Surgery at Mass Gen. Originally from Chicago, he trained in neurosurgery at the University of Illinois and completed a combined neurosurgery and orthopedic complex spine fellowship at Cleveland Clinic. Dr. Shin specializes in complex spinal reconstruction surgery and oversees a diverse portfolio of spine research in data science, artificial intelligence, biomechanical engineering, laboratory investigation, clinical trials, and spine outcomes research. Dr. Shin also serves on the editorial boards of the Journal of Neurosurgery Spine, Neurosurgery, and Neurospine. He's frequently invited to teach and train surgeons internationally and has directed spine courses for the North American Spine Society, Congress of Neurological Surgeons, AO Spine, and the American Association of Neurological Surgeons. Dr. Shin, thank you so much for taking the time to be here today. I'm now going to turn the floor over to you.
Great. Thank you, everyone. It's a pleasure to be here, and I'm really excited to share some of our experiences in implementing augmented reality in spine surgery here at the Massachusetts General Hospital in Boston. Over the next 20-30 minutes, I'd like to share with you some insights regarding how we implemented this program and some of the features of this, showing some interoperative photos, videos, and some illustrations that I think will really highlight what this technology is all about. And so again, thank you for tuning in and for having me today. So as everyone knows, in the last decade or so, we've seen a real explosion in the application of computer-assisted technology in the operating room. Specifically in the domain of spine surgery, navigation has really changed the paradigm for surgeon accuracy and our ability to do a lot of different types of surgeries, whether open or minimally invasive. With that, we've seen an explosion in various platforms using computer-assisted navigation, and this has really generated a great academic and practical discussions regarding which technology to use, how effective they are, the value that they provide not only to the surgeon and the patient, but also to hospital systems. And ultimately, it's about improving the safety of surgery and also the accuracy of what we do as spine surgeons. And I'm going to demonstrate some of the features of this augmented reality technology. So why is this important? Well, this is important because when we're talking about spine surgery, whether you're doing something MIS, single level, or multiple levels for deformity, accuracy is important. And as everyone knows here, placing of instrumentation is very important, but it's not the only part of the operation. It's one part of many different phases or components to an operation, including decompression, deformity correction, interbody, whatever you name it. There are a lot of different components, and so really optimizing the accuracy of this part of the operation is very important to minimize complications that are in general avoidable. And so you can see here, these are some representative CT axial images demonstrating what we see and what I think most have seen, whether in their practice or other practices, with screws that are possibly lateral to the vertebral body, screws that are medial to the pedicle, perhaps in the foramen. And the implications of this is that this could affect a nerve root, resulting in a new deficit or new motor sensory changes for that patient. And sometimes, when the screw is really in the wrong place, it can cause significant damage to the spinal cord, and that is something that we obviously want to avoid. And in some cases, depending on where you are in the spine, whether it's cervical, thoracic, or lumbar, we have to think about the regional anatomy and also the proximity of vital organs and other structures that are not necessarily the focus or, within the specific area of visualization, but these are important structures that are around the structure we're working with, and specifically in the thoracic spine, great vessels like the aorta are important, as depicted here with the red circle. So why is this important? Well, safety is important, right? This is why we're trying to investigate, develop, and innovate in this domain, is to really think about how are we going to optimize outcomes for our patients. And one of my colleagues, Rajiv Sethi, has done a lot of work in this domain and wanted to highlight one of these papers looking at safety in complex spine surgery. And he brings up a really great question in this paper, which has been presented, is that, is a misplaced pedicle screw really acceptable in this modern era with so many different technologies that we have? And when we think about it from a hospital and system standpoint, how many of these implant-related complications is a surgeon, hospital, or center willing to take on when there are tools available to improve the accuracy? So these are questions that I think everyone is thinking about, and rightfully so. And so now that we have this continuum of computer system navigation, now we've seen a lot of growth in robotics, and now with augmented reality, the question is, what is the optimal workflow? What is the value presented to the patient as well as the surgeon and hospital? Now, freehand technique is very effective. Full disclosure, this is, I primarily use freehand technique for most of my cases and traditionally have done so. That's how I was trained. I was a fellow at the Cleveland Clinic. And, whether it's in the cervical, thoracic, lumbar, spine, pelvis, freehand technique is really robust. And this is just a slide demonstrating what most surgeons are familiar with in the thoracic spine are the different freehand techniques for straightforward or anatomic approaches in the thoracic spine. And whether you use C-arm fluoroscopy or use lateral x-ray to visualize and determine your angles, and use local reference marks in anatomy to place screws, this is robust. And many surgeons, including myself, use this on a daily basis. And there's a lot of literature demonstrating the effectiveness of this. But the question becomes, is this as accurate as we can be, especially in more complicated operations, revision operations, extension operations, or operations where maybe the visualization is not so great, for example, in minimal access or minimally invasive procedures. So there's been a lot of interest in navigation and robotics, and there are a lot of different vendors out there with new systems that are coming out, and if you read Becker's or any trade magazine, you're going to see a lot of these highlighted. You see a lot of surgeon champions highlighting technology, as well as hospital systems really trying to gain favor in their marketplace to highlight the adoption of these enabling technologies. And so with this, there's been a lot of interest academically to study this in terms of, is one more effective than the other? How do these compare to traditional techniques? And so we studied this as well. We recently published a paper in the Spine Journal looking at the safety and accuracy of robot-assisted pedicle screw placement compared to conventional freehand technique. And this was a systematic review and meta-analysis, and the citation is here for anyone who's interested in taking a closer look. But essentially, I was really interested in just surveying the literature given the explosion in technology and the rapid adoption and utilization of robotics, just to see, what have we learned so far from those surgical pioneers and innovators. And interestingly enough, the data for the most part demonstrates that there's very high accuracy depending on how you grade it, but the placement of pedicle screws is very accurate, when you use robotics compared to freehand technique, looking at the literature. Overall, it appeared that robotic-assisted pedicle screw placement used significantly less radiation, although the length of surgery was significantly higher when we looked at this. Now, we can argue the merits of systematic reviews, looking at various types of surgical data, but I think looking at this from sort of a broad standpoint is very helpful because it gives us some perspective on what's going on today. Well, we know that navigation has limitations, right? We can talk about the financial limitations, the implications to a hospital system or hospital with regards to cost. But from a practical standpoint, one of the limitations is that, for the most part, as a surgeon, we have to take our eyes away from the field. Now, for a minimally invasive operation where you're making a smaller incision and we're not really exposing the spine, there's not a lot to look at directly in the surgical field. But for open operations where you have a lot of different anatomy to work with, including the nerves, nerve roots, spinal cord, cauda, equina, taking the surgeon's eyes away from the surgical field can have drawbacks, especially when you're passing and using a lot of instrumentation and instruments around these neural and vascular structures. And then we have the practical aspects of navigation in terms of the training of your OR staff, familiarity with the techniques, the time to develop an efficient system within your OR, as well as the contamination risks. So augmented reality really came onto the scene, and some of my colleagues, neurosurgical colleagues at Johns Hopkins, really have done amazing work really driving this forward, and they've published a number of their studies here in the journal Neurosurgery as well as Neurosurgery. And specifically, I know Camila Molina and Tim Whittam have really been the agents to promote and demonstrate the feasibility and efficacy of this technology, where essentially the surgeon can keep their eyes and hands in the field using sort of real-time tracking to place instrumentation. And they just put out a study in October of 21 from JNS Spine demonstrating the screw accuracy, which I included the table here just so you can see. And again, the citations are all here for anyone who wants to take a closer look. As you can see here, in terms of grading the accuracy of the screws, you can see that 98% of these screws, more than 200, were placed with a grade A or B. So going back to this question of value and whether this is the right system for you, we're not going to get into that, but it's a great question to raise and something to think about in the back of your head while you're watching these slides and as we go through this. And this is, again, this is a great paper by Raj Sethi and his group thinking about spine safety and the component of technology within that framework, which I think is very helpful to think about. So let's talk about AR and let's dive a little deeper. So, I think as a spine surgeon, we're thinking about how we're going to push this field forward, how we're going to become more accurate, and how can we bring in all these data points into our surgical field so that we can really optimize our efficiency and accuracy in surgery and truly sort of become super soldiers, right, as super surgeons, and having all the information at our disposal without having to take our eyes out of the field. And as surgeons, we're dealing with numerous data points and a lot of information throughout these cases, whether it's communicating with anesthesia, looking at the vital signs, thinking about the implants, making sure that we have everything we need, communicating with our OR staff, the nursing, the scrub techs. There's a lot to process. In addition, we also have to get the work done. We've got to recognize and also implement the plan that we're trying to execute. And so when I was trying to describe this to my kids, my son basically said, oh, it's like you're kind of like Tony Stark and Iron Man. I thought that was a really great analogy because I was really trying to explain how this augmented reality system is really putting information within my visual field so that I can execute the surgery without being distracted and taking my eyes out of the field. And so before we get into some of these slides, I just want to put this out there that all the patient images and the people shown here have consented and agreed to have their images presented. And you'll not find any patient identifiers. These are real intraoperative images and video, and they're used for illustrative and descriptive purposes. And I hope that this will really illustrate the practical implementation of this technology. And we'll have time for question and answers after the session. So to kick off, here's this case. This is one of the first cases that I use this with. And this is a patient who had a multi-level posterior lumbar fusion operation several years ago at another hospital in different states and presented with significant pain and disability related to severe stenosis and also PJK, proximal junctional kyphosis, failure, and pseudoarthrosis and pull out of the instrumentation, as you can see here. All the way to the left, these are standing scoliosis x-rays demonstrating that globally has a really significant impaired sagittal vertical axis and really has inability to stand upright with a pelvic tilt more than 20 degrees. And you can see up top that there is significant proximal junctional kyphosis here with angulation really at the top proximal segment. CT scan demonstrates that there's some correction of that PJK when he's supine, but you can see the sort of the vacuum disc changes in those adjacent disc spaces, as well as lucency around that top screw and some evidence of pullout. The coronal reconstruction shows that there is significant bone mass around some of these areas on both sides, left side more than the right. But then the axial imaging demonstrates, as you can see on the top right, that one of the screws on the left side has a medial breach. This patient has severe back and right leg pain in the distribution of that breech screw. You can also see the lucencies around the instrumentation, and also at the most caudal aspect of the construct, you can see a medialized lumbar screw at the lumbosacral junction, again with evidence of lucencies and pullout of the hardware. So this patient underwent revision reconstruction surgery, and there are a number of challenges here. I think we can talk about the challenges from a deformity standpoint, what are the goals, but my purpose in this case is really just to highlight, using this technology to help me better plan as well as execute new screw trajectories given the large fusion mass that was there before, as well as helping me really see what is normal and what is abnormal. I think any surgeon who's been in this context knows that in a revision context where there's so much scar tissue, excess bone, there's fibrous material around the screws, there's a lot to work through. It can be very difficult to know where the nerves are, what's nerve, what's scar tissue. And so this was my thought process in utilizing this to really test it and push the envelope with regards to stressing the system and see how it can help me in this context. And as we rolled this out at the MGH, we have an incredible neurosurgery residency training program. We have about 3 residents a year. And here, these are 2 of our residents. On the left, this is Amy Bauhan. She's a senior resident. On the right, that's Christine Lee, one of our current chief residents. And here, in anticipation and preparation for this case, we had them practice on sawbones with our Augmetics team, who have been phenomenal. And here you can see they're in one of our office spaces using sawbones and taking the simulator, like a flight simulator, and really practicing with the ergonomics of the headsets, understanding, the working distance, as well as understanding how to navigate and use the instruments relative to the reference frame, as you can see here. And so we did this in our training program. We rolled this out and had opened this up to every single resident, and so that they can really get their hands on this and practice and rehearse this before surgery. And this is ongoing. We do this for every case that we're planning. At the time of surgery, this patient is prone, and to the right side of the screen, that's cranial, left side is caudal. Exposure is performed, so this is a T10 to pelvis, lower thoracic to pelvis exposure with plan for instrumentation, revision of the hardware, multi-level posterior column osteotomies, and decompression. And as you can see here, given the length of the exposure and the need to place instrumentation at the thoracolumbar junction, above and below, as well as into the pelvis, we have two different reference arrays that are docked accordingly. So for the upper part of the construct between T10 and, let's say, the upper lumbar spine, this is a spinous process clamp device, which I think with any navigation system, you're going to see a very similar type device, which is basically clamped on rigidly to the bony surface there. And given our desire to revise the instrumentation at the lumbosacral junction, as well as place iliac fixation, this is a pin and reference array that goes directly into the iliac crest. And this system has various hinges and swivels, so it can rotate in multiple dimensions, so that you can really think about how you're going to put the screws, you know, where your hand's going to be, the trajectory that you're going to use so they don't bump into each other. And so that can be very effective. And these are just the reference arrays that are placed while the imaging is being performed. So the exposure is performed for this case. We clean out as much of the previous debris that's there, the scar tissue. I take out all the hardware. I smooth out all the bone surface that I want, just to make sure I can see as much of the anatomy as possible. Place the reference clamps, and then drape the patient and get our intraoperative CT image. And this is what that looks like. And so this is a view into the operating room here at the MGH. And you can see anesthesia is towards the left of the screen. Again, the patient is prone. We have our instrumentation all lined up in our all our surgical supplies. Then we see the O-arm coming in over the Jackson table. And you can see here there's no reference array. So we have basically a screen here for the augmented reality navigation for everyone in the room to see, although we don't need to necessarily see that as the surgeon and the trainee, but that's there. And everything else is just part of the normal operating room, and everyone here is probably familiar with that, with the suction and the towers with the Bovie cautery and whatnot. So we cover the patient, we get the O-arm spin, and for this case, there are two spins that are obtained. And again, this is another view of that now from essentially the head of the table from the anesthesia side. You can see the O-arm has been sort of collapsed around the patient. Everything is done sterilely here, and you can see that this is just the boom tower with the implants. But again, there's no reference camera or array, just the tower to basically see what we need to see. These are the headsets for myself and our trainee, and basically it's a battery pack with a headset that, after the exposure is done, we take off our loops, the O-arm spin is done, put on the headsets, get everything calibrated, and we're ready to go. And this is what that looks like. So we scrub out, put on our headgear, O-arms coming in, and after the CT is done, we then can look at the images. They're transferred to the navigational platform, and we can play around with it a little bit in terms of optimizing windowing. Here, what's in blue, those are my retractors I left in. In some navigation systems, you have to take the retractors out because there's too much artifact, but I wanted to really stress the system and try to see sort of what I could see with everything in, while not really disrupting my own customary workflow. So we kept the retractors in, and here, we can play around with the imaging to optimize the visualization. And so here are some images of, then putting on the actual reference array, confirming and registering different instruments. Here, this is a gear shift probe that is being registered, and eventually, the gear shift, and as well as the screw being registered. And the great advantage also is you can navigate essentially any instrument, including the drill. And so I find that very helpful, being able to navigate the Midas drill as well as the instrumentation systems. Here again, just another view of that. This is myself, and this is my chief resident, Christine Lee here, who's assisting me in this case. Again, registering the gear shift. And then once we're done with the superior part of the construct, then basically attaching the reference array to the array that's in the iliac crest. And this is one of our junior residents, Ian Connolly, who's interested in spine, who is also involved in this case. As you can see here, just switching that reference array, so now we can work on the lumbosacral junction and the pelvis. And here's an illustration. This is a video just demonstrating placing that screw. You can see the previous trajectory from a screw that was placed before. Pedicle screw comes down. Again, this is what everyone else in the room is seeing. And I'm going to have some shots of what we are actually seeing as the surgeon. And so on the next slide, this is going to demonstrate basically finding the landmark. That's been the starting point's been drilled and marked with a red marker there, and then lining up the driver with the trajectory that was saved and placing the screw. And this is in the thoracic spine. And you can see just from the silhouette here that our eyes and hands are constantly in the field. We're not looking across the room, not trying to get the instrument, to capture any kind of camera, but looking directly into the field. And here again, just another way to look at that. Here we have, again, we've got the screwdriver with the navigation array. Ian is looking directly into the field. You can see his eyes looking down into the field in control at every single time point. Same thing, working down, eyes looking into the field, having great control and visualization of those landmarks. And so this is me taking Ian through just an example of how that works, for the first several thoracic screws that we're placing. And here, I'm just talking him through the anatomy, getting the gear shift in. And the whole time, I can see what he's seeing through the viewer, the headset. I can see exactly what he's seeing, and also the trajectory with the navigation in the axial and sagittal plane. So this is very helpful because we can plan and measure our implants before, and then gear shift, then place the instrumentation at the depth and the trajectory that we're shooting for.
Yep, good. Take it out.
And here, this is an illustration of navigating the Midas to place iliac screws. This is very effective. We've found it's very effective for placing instrumentation into the pelvis using this technology.
Ready? Yep.
And here are some videos of my other chief resident, this is Author Malik, who is one of the first screws that he's placing. You can see he's carefully getting that driver into the pedicle. And this is the view that we're seeing live, that I've captured through the headset, through the video. This is what I'm seeing, and you can see how that augmented visualization can really help us out. You can see the actual augmented version of the screw, as well as the augmented, sort of the superimposed CT anatomy over the patient.
Ready? Yep.
And just to highlight that again, so, you know, from where I am, this is the view through my lens here, and this is what he's looking at. So he's looking down into the field, looking at the anatomy, but also seeing the navigation, the axial and sagittal planes in real time. And you can see that clearly as we're going down, the spine is getting more and more comfortable with that in terms of placing the instrumentation. And this is just a view of the thoracic spine. You can see the depth and trajectory of the screws, and these are revised sacral screws, and also the trajectory of our iliac fixation. And again, this is just a screenshot of what that looks like intraoperatively when we're seeing, you can see the actual driver, you can see the augmented sort of view of the driver, the screw, the local anatomy. This is the iliac crest from that CT scan superimposed over the anatomy of the patient, and again demonstrating the axial image as well as a sagittal reconstruction live. So what about future directions? Well, right now it's a great tool for placing instrumentation, but I think for a lot of surgeons we're thinking, well, what's next, right? And we recently reviewed sort of applications of navigation in deformity oncology surgery, specifically beyond screw placement. And I think this is a real interesting area of research as well as innovation. And in this paper, again, we surveyed reports that were published over the last several decades and basically found that, you know, in areas of deformity and oncology surgery, you know, surgeons across the world have navigated various instruments, including osteotomes, minimal access dilators, chisels, probes, you know, drills and whatnot. And I think this is a real interesting, exciting area for what we can do with augmented reality, and that, you know, can augmented reality give us actual real-time feedback in terms of looking at anatomic points and then providing information to help optimize surgery for things beyond instrumentation placement. Because if it can help us perform osteotomies, help us guide the extent of decompressions, realize, you know, what's normal and abnormal anatomy, I think that will really be incredibly important and helpful, and will really help move the field forward. Why is that important? Well, in deformity surgery, there are a lot of landmines and complications are high. And I've always been interested in applying navigation in complex cases, particularly cervical deformity, and we previously published our experience using navigation in planning 3-column osteotomies for severe cervical thoracic deformity. And, you know, with these type of operations, you can imagine with the spinal cord, nerve roots, vertebral artery, a lot of different structures in that area, you know, having to really take your eyes out of the field, it can be a distraction. And in one of the earliest cases, I put this slide up. It demonstrates sort of what happens when the visualization is not great. And whenever doing any type of 3-column osteotomy, especially at the cervical thoracic junction, the visualization is really poor. It's really poor because it's bleeding. You can't retract the spinal cord. The vertebral artery may be in the way. The nerve roots are there. Functional nerve roots are there. So we really have limited visualization and exposure. And what can happen? Well, if the osteotomy is not executed well, then you can have what happened here in one of my cases, where we basically went too far and disrupted the most ventral cortical surface and eventually led to a subluxation of that vertebrae, which can be very difficult to treat and repair. So even though we improved the kyphosis, it's really not the result that I wanted. That's not any fault of navigation, but I'm just saying that it just speaks to how enabling technology can help us become more accurate in the sense. And this is just a screenshot of how I use navigation in that context. You can see this is a probe that's placed deep, and you can see this is on the wall of the C7 vertebral body. And again, the sagittal view shows the orientation of that probe deep into the body. But what's somewhat cumbersome about this approach is that when I'm doing this, you have to, put down one instrument, pick up the probe, look at the screen across the room, kind of disrupt the workflow of the operation, and these operations take time as it is. And so I think optimizing efficiency, I'm very interested in using this technology. Well, what about other cases? What about cancer cases? What about tumor cases? This is a sacral chordoma. And what about using navigation to plan osteotomies and cuts to make sure that we have maximal resection margins, bone, soft tissue? And especially a case like this where, this is around the S2, S3, S4 nerve roots, close proximity to the bowel, making sure that navigation can help us dissect freely around these structures to not only achieve oncologic margins and maximize the effectiveness of the surgery, but also to improve the safety profile for the patient. Or again, like I mentioned before, what about a cervical deformity patient who needs a 3-column osteotomy? How's navigation? How's that going to help us? Which leads me really to my last slide, in that I love this picture because I think it really captures, some of the challenges that we face in spine surgery, and that similar to pilots, where I think landing a 747 at night seems like a very difficult task, one that many of us may take for granted, but looking at a picture like this, it just shows you how many different inputs and how many different data points are needed to really execute that safely and well with so many lives at stake. And I have no idea what all these numbers and gadgets are here, but it really spoke to me because it really captured for me the essence of how augmented reality can really enable and enhance the surgeon's perspective and experience with regards to putting a lot of these data points into our surgical field so that we can execute these safely. So I'm really excited about where we can go with this technology, and the implications of this also in our training programs and in inspiring and also training our future leaders in neurosurgery and in spine surgery in general. And so that's all I have. So that being said, I'd like to really thank, there's so many people that were instrumental in helping us kick off this program at the MGH, including my chair, Bob Carter, with whom this really would not be possible, as well as the numerous hospital administration, OR, nursing, radiology techs, the scrub techs. It was really incredible team effort to do this, and most importantly for today, our Augmetics and Becker's team for hosting and supporting this webinar. So I hope this was informative and helpful, and this is the conclusion of my slides. I'm happy to take any questions at this time. Thank you very much.
Fantastic. Thank you so much, Dr. Shin, for that amazing presentation, and just really exciting to kind of see the technology and how it works up close and personal through some of those videos. Just a reminder to the attendees, we will now jump into the Q&A section of the webinar. It looks like we've got a few questions coming through already, but please continue to type your questions into the chat box, and we'll get to as many questions as we have time for today. So, Dr. Shin, let's jump into the first question. First question for our audience member is, what was the functional outcome for the patient highlighted in the OR?
This patient has done very well. So this patient came in, as you can see from that initial scoliosis X-ray, that patient had significant back and leg pain related to the deformity. And so that patient is now standing more upright and has gone through physical therapy. And as you know, the recovery from these deformity operations takes several months, and that patient is overall doing well. And I think for the objectives of the operation, which were to improve the alignment as well as improve obviously the placement of the instrumentation, taking it out of the foramen, away from the nerve roots, and decompressing the nerves. The patient did very well from that standpoint. Thank you for that question.
Fantastic, thank you. Another case-specific question that's just come through is, do you have to redo the CT spin when you accidentally hit the reference frame?
That's a great question. I've not had to do that because I think in implementing this for myself, my staff, and as well as the residents, we really try to emphasize not to touch it, and to really stay away from it. And so I think that when placing the reference array, whether it's on the spinous process or docked into the iliac crest, I'm really careful about where that's going to be before we mallet it in or attach it, and thinking about the profile of that array and where our instruments are going to, where they're going to pass from that standpoint. But I would say that with this system, someone asked, I saw in the Q&A what the name of it. It's the Augmented system. With the system, you do have to verify the instruments relatively frequently. And so with that in mind, we're constantly checking the accuracy of the implants to the local anatomy. And with so many different bony landmarks, it's pretty easy to do that. So whether you're verifying the drill or the gear shift or the actual screw itself, because we have to essentially verify that instrument when we're using it, we check. But I have not had to repeat an Oarm spin because of a concern for accuracy so far.
Got it. That makes sense. Thank you, Dr. Sheehan. Next question coming from audience member is, from your hospital's perspective, how does this compare to robotics from a clinical and economics perspective?
That's a great question. I think that anyone who is involved in any type of value analysis for their institution, whether a surgeon or administrator, I think these are very important. So I would say that it's different. It's different from robotics, I think, because I think in general with robotics, there's a significant capital outlay. And for most of the robotic systems, there's also an associated sort of value spend association with the implants. With this system, this is not tied to any specific vendor, so you can use this augmented reality system with essentially any instrumentation system that you use, either as a surgeon or if your hospital or hospital system has specific contracts with preferred vendors. It does not necessarily mean that you have to use one or the other. And I think that was a major advantage and was a way that I think helped facilitate this at our institution. And I think that, it's also from a work standpoint, I think just the footprint of the technology in terms of the storage space of the technology and the hardware involved, it really does not take up much space. So I think from a number of levels, it's been advantageous for us. But I know most systems and hospitals are looking at robotics and different enabling technologies.
Got it. Dr. Sheehan, along that same wavelength, another attendee has asked, what is the capital process like compared to other large purchases your hospital has made?
Well, I think that, every individual hospital is different, I think, in terms of their finances, their budgets, and processes. So, like in our system, we have to present, what the technology is and really make an argument for how this can ultimately improve outcomes, not only for the patient, but also help streamline different processes in the operations management. So, I can't speak to the financial details. I think that the specific Augmetics vendor, they can probably speak to that specific process offline. But I would say that, for me as a surgeon who wanted to bring this into the system, it is something that I had to, make an argument for amongst peers, colleagues, as well as hospital administrators, as well as various levels of, clinical administrators, including nursing and operating staff.
Got it. Dr. Shin, for surgeons who are looking to adopt the Augmetics X-Vision system, one audience member has asked, can you walk us through your initial cases, kind of outline what types of procedures were identified, and what does the learning curve of this technology look like?
Right. So, for me, given my scope of practice, the first several cases I did were cases exactly like this, to this degree. I did not use this in my initial cases on single level cases or 1 to 3 levels. I really wanted, from my own perspective, I really wanted to stress the system and see what it could do. So, I think my first, several cases were flat back deformity, PJK, something of that nature, multiple levels involved. Just like I showed in the slides, we really just, we're methodical. We planned a lot in terms of training the residents, training the staff, in services for the scrub tech, the nurses, the circulator, as well as the radiology techs. And we did that, in collaboration with the Augmetics team and all our staff. So we rehearsed that quite a bit. And then I think day of that first operation, it's go time. And I think that part of the learning curve was really understanding, how to maximally use the instrument that you're using at that time without having the need to repeat the steps. So specifically, I think one of the things that I learned during that first case was, I like to make a starting point for my instrumentation with the Midas, with the drill. And so instead of doing every step for every level, let's say starting at the T10 level, I know I'm going to go from T10 to S1, instead of registering, confirming the drill, the gear shift, then, the screw, and if you tap, the tap, instead of doing all those steps for each individual level and then doing it again for the next, I basically would take the Midas, register it, and then make my pilot holes, my entry points for as many levels as I could see with that registration from that Oarm Spin. So that could be from T10 to L2 or L3 or whatnot, and just use that instrument, register, verify it once, and make those starting points. Same thing. Then I would take my gear shift, register it, and then go from T10 to L2 or L3 and use the gear shift to navigate the trajectories that I wanted. And then having planned and knowing the screw sizes, diameters, length that I wanted, then, the scrub will have all that ready, and then we can go ahead and just, bring in the driver in and out instrument. And so, with a large case like that where we're instrumenting so many levels, that was literally the learning curve was significant for that one case with each level. That's sort of what I learned that first case. And so by the time we did the second case, things went by much, much faster because, those are just sort of the learning points from the first one, and we didn't want to, go backward. And so I think that from that standpoint, it was pretty easy. And, the one thing I would say that the challenge, I think, is of the system is just needing to verify the different instruments and reminding yourself that you need to do that, which I think on one hand you could think of as a safety check, going back to what that other participant asked with regards to accuracy. But on the other hand, you could see it as a disruption to your workflow as you're having to register instruments again. But again, I think once you do 1 or 2 cases, you really get the workflow of that, and so it's not really a consideration or a concern of mine anymore.
Gotcha, that makes sense. A quick follow-up to that question from another audience member was asked, has the implementation of augmented reality significantly altered your previous operative workflow?
Well, I think that the workflow is actually very similar because I think from, exposure to placing the reference arrays, the Oarm Spin, the time is quite similar. And like I said, we just launched this program, so, I don't have a wide range of cases to share with you in terms of, MIS and different applications. Have not done that yet. Excited to try that. But I think so far from what I've experienced with some of these larger deformity cases, it is really, it hasn't changed the length of surgeries. The time of surgery is not any longer. I think that the actual utilization, the workflow is quite similar, because I think that, whether you gear shift, probe, cap, whatever you're using in your workflow, it's the same idea with regards to having navigation capability. It takes a little time, a couple minutes, just to get oriented to the actual display that you're looking at. And I think that, and getting used to sort of clicking it on and off and looking at the 3D. But, I liken it to sort of playing a video game. It's like once you start playing video games and you get the hang of it, you really learn that spatial orientation. But that's pretty quick to learn.
Got it. Dr. Shimmy, one interesting question that's come through, specifically talking about the headset. Did you find yourself having to place your head in a particular angle or position to visualize the instrumentation, since the tracking cameras are only from the headsets?
That's a great question. Not specifically, no. I mean, I think that the great thing about this is that the augmented, so the navigation image that you're seeing there, and again, it looks a little grainy on this picture just because I had to be creative in terms of how to capture that, because there's not a live camera on the headset itself, but I really wanted to demonstrate to the viewer, what the surgeon is sort of seeing in essence. So, I think that the advantage is you can click it off so that you're really just looking at the anatomy, the normal anatomy that you want. And, that's been a great advantage, because essentially I kind of use it as a test for our trainees, because I still challenge them to find the starting point and to show me the trajectory of the screws as if they were doing a freehand. And then they'll basically click on the augmented reality to verify and confirm, what they're thinking. So it's a great way to reinforce what they're doing. But, I think that, again, going back to the previous question, I think when you first put it on, the image is really clear, crisp, and bright. And so it's like having this LED in your visual field. It does take a little getting used to, but again, because you can turn it on and off, and there are other variations of what you're seeing, for example, sort of what's in that green circle. So there are ways to change that visualization, but it doesn't change how you operate. I don't have to, hold my neck in a certain way. It's very similar to just like wearing a headlight and loops, for that matter. It's just getting used to, how to sort of process and deal with that added information that you project onto your visual field.
Got it. That makes sense. Thank you for walking us through that. And another audience member asks about the next generation of spine surgeons, residents and fellows, some of which that were featured in this webinar. How do you feel augmented reality will prepare your residents and fellows for when they come out of training?
Yeah, that's a great question. I mean, I think that, like I said, my full disclosure, my bias is I train with freehand technique, and that's really the workhorse for what I do. And so, I don't want to say that I was skeptical with, these different technologies, but, I really wanted to stress it out and to challenge what it could do, because, I feel that whether it's, T10 to pelvis or something else, and I think that for most surgeons who are comfortable with and familiar with freehand, you can do it pretty quickly and expeditiously. And so I think for me in a training environment, I still want my residents, trainees to be able to place instrumentation, whether or not they have these technologies, whether or not they have navigation or someone to work a C-arm, if there's a trauma case, emergency, late at night, holiday, weekend, whatnot, COVID, this or that. I still feel like, we should still be able to instrument and do those type of operations. So from my standpoint, the goal is it's about, learning how to apply these technologies to augment and literally enable and enhance the surgeon's capability. And I think for residents, really using it as a tool to help verify what they're thinking. And so I think for especially the chief residents that we're working with, it's great because, you know, they're on the launch pad ready to leave, and it's really giving them an opportunity to really test what they know with regards to surface anatomy, spine anatomy, and techniques. So I think that, you know, clearly with robotics and navigation, augmented reality, there is an explosion of this technology, but I do think that there is still a lot of value in training residents to understand when to use it and how to use it.
Got it. Thank you, Dr. Shen. We still have a bunch of questions coming through. We're just coming up on 1 p.m. We'll try to get through 1 or 2 more before we wrap up today, but please do continue to answer your questions. Dr. Shen, next question from an audience member. What are you looking for when evaluating these technologies for adoption? What outcomes do you focus on?
Well, I think that what's important is accuracy. So I think that, you know, when I was looking at this, I did go through those papers that I highlighted on one of those previous slides. I'll try to pull up here. I tried to, I took a look at these papers, and I really went through them. I looked at the feasibility study, the cadaveric precision and accuracy. Really interested in that and seeing, you know, what that meant, you know, in terms of the radiographic outcomes. And, you know, I think, as I mentioned before, you know, placing screws is just one component of this operation, right? You don't want that part of the operation to take hours and hours. You're never going to go home. You're never going to get home. So for me, I think that initially is all about, you know, the clinical safety and efficacy and accuracy. That's really what I'm looking at, you know, in terms of adopting this and rolling this out. And for these patients, you know, we're prospectively recording the data and analyzing it. And these patients are getting CAT scans post-operatively, and the accuracy has been outstanding. So, you know, we're assessing that critically with the rollout of this technology, studying that prospectively, you know, grading the placement of each screw, and comparing that to the normal anatomy on the CT scan from pre-op. But in terms of what specific outcomes I'm looking at, yeah, I'm looking at the accuracy of the instrumentation.
Got it. So accuracy is obviously paramount. Dr. Shen, it looks like we've got time for one last question, and we've got a technology-specific question here that could be interesting to finish on. If you could add more information to the present navigation view, what would that be? Additional visuals, text, anything else?
Yeah, I think that what would be helpful is, you know, being able to change as well as modify the visualization of what's on that screen. I remember the first time I tried this, the image is so clear and bright, you know, I by impulse, I wanted to reach out and like touch it, you know. And a similar analogy I have is, I don't know if anyone's seen the movie Minority Report with Tom Cruise, but it's like I wanted to reach out, touch it, spin it around, move it around, and like move it out of the way, you know. But I think that would be great. And so one of the things I wanted to be able to do is to basically like use my hand to twist and turn and get a little more three-dimensional visualization that's there. You know, I think that, you know, the company can provide like a mock-up or a cartoon, I think, of what the actual still is. You know, I know that this didn't come across great on the picture, but, you know, I can see the screw, the plan, the screw trajectory that was saved. You can see the diameter and the length, but it would be great to manipulate that image further, rotate that, get other views, not just axial and sagittal. You know, I think that would be very helpful.
Fantastic. Thank you again, Dr. Shen. Really, really appreciate that, your time. Excellent presentation today. And thank you to our audience members for those fantastic questions as well, and also Augmetics for sponsoring today's webinar. Please, to learn more about the content today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today. We hope you have a wonderful afternoon.
Great. Thank you, everyone. Have a great day.